I'm Mark Campbell. I'm a medical oncologist in Grand Rapids, Michigan. I'm going to try to help you understand what neoadjuvant chemotherapy is. I wanted to talk a little bit now about a newer therapy that is becoming evolutionary, more important in our strategies, and that's something called neoadjuvant. Now, neoadjuvant, when I first heard the term neoadjuvant, I thought it meant new. It really kind of means before, and in this context. And adjuvant treatment is our fancy word for more preventative, where you're doing it ahead of time. We take the flu shot often in October, November, for the flu in January, because it needs to be in there working prior to the exposure, rather than waiting till the flu comes and then trying to give you the shot. It just doesn't work that way. So we're giving adjuvant, more or less ahead of time, preventative in a context, and we're doing it. Why would we do that? And I want to illustrate it with three of the more common cancers that we see. I'm going to use lung cancer, I'm going to use breast cancer, and I'm going to use colon cancer to try to illustrate the same general concept. And I understand this is purposely simplistic so we can better understand it. Mom had, again, a 3-inch tumor there. What works next is our immune system. Part of our immune system is the lymph nodes. And the lymph nodes are all over our body. They kind of each police a different part of the body. So if I had an infected toenail, the lymph nodes here take care of it on that side. If I had an infected finger, the lymph nodes in the armpit. If a breast issue, again, the lymph nodes in the armpit. So each part of our body has anatomically an assignment, so to speak, of, like police departments, of lymph nodes that help police that. We get a sore throat, the gland swells up, fights the infection in the tonsil perhaps, lymph node swells down, and goes back to surveillance. So we have lymph nodes. In the case of lung, they're in the area we call the hilum, the Y there. In the case of the breast, there's kind of a long number of them, 20 or 30 or more, in the armpit called the axilla. And the colon, if we had a tumor start inside the colon, it's all contained. But after a period of time, it can burrow its way out, and the lymph nodes in that adjacent area will try to act as a containment so that it doesn't go beyond that. Same thing in breast cancer. If there some seeds were trying to migrate, they would usually, not always, usually go to the lymph nodes in the axilla, and they'll try to work their way up, and we don't want them to get away. In the case of my mother's, they would go to the hilum, and you don't want them to get away. Well, if we have this cancer, emotionally, I understand it. Emotionally, we got to go in right away and get it right out. That's the emotion. But the one that threatens the person's life is this guy, not the main tumor. We need to work on it, don't get me wrong. But we have to know and determine whether as best one can, remember how tiny one is, you can't see it. Is there a seed out there? Because if we don't get that, you can't expect the surgeon to remove it when they can't see it. They want to be wide, but often with anatomical structures next door, they can't always do that. And so we could have a little seed just beyond. And we have to take him out, again, for the drug-resistant reason. We got to take him out while he's little, not letting him become a half an inch, because now there's a billion, and that may exceed what we can kill. So this strategy of neoadjuvant says, well, if, and I'm making up these numbers to for illustration's purposes. The main tumor might represent 95% of the problem. These little seeds that are in the lymph nodes might represent 4% of the problem. And again, this little theoretical cell that's way outside the sphere might be 1% of the problem. But again, what threatens the person's life are the outer two rings. So we have to start sometimes therapy, sometimes radiation, sometimes chemotherapy, sometimes the two together, sometimes to try to sterilize the outer rings. And in killing the outer rings and maybe killing the main tumor down to a smaller number, then the important thing for the surgeon is they don't have as risky a situation of having these seeds beyond the area that they're able to see with their naked eye. So neoadjuvant therapy would come in and say, maybe we give some chemotherapy, commonly, hormone therapy, immune therapy. Maybe we give some therapy to help surveillance the rest of the body, and then come in and do the surgery after we, so to speak, sterilized the outer 2 rings in my analogy.